In the field of treatment of digestive neuroendocrine tumors at ESMO, I will mention three important studies. The first one is called HEPAR, which studies the combination of PRT and radioembolization. The second one is CLARINET FORTE, description of the population of this study, double dose of lanreotide in patients progressing with the conventional dosage. And finally, the SANET-ep study, which studies a new tyrosine kinase inhibitor, Sorafenib, in patients with non-pancreatic neuroendocrine tumors. The HEPAR study is related to the concept that PRT, peptide receptor radionuclide therapy, is an effective modality for treatment of metastatic neuroendocrine tumors, but it could be improved by adding something more directed to the liver. And in this case, it is radioembolization with Holmium 166, which is performed in the weeks following the last course of PRT. It showed that this combination of PRT and radioembolization could achieve in patients who have a big tumor burden left after PRT a very good response rate, more than 40% according to RECIST criteria. This was at the expense of few side effects. However, one patient had a fatal liver failure due to radioembolization. Quality of life was preserved, except in the very first weeks after the procedure. I had the pleasure to present in this meeting the population included in the so-called CLARINET FORTE study, which comes after the CLARINET study. CLARINET was a randomized controlled study against placebo in patients with well-differentiated metastatic or advanced neuroendocrine tumors from the pancreas or the midgut, showing a very interesting result because lanreotide 120 milligrams every 28 days was shown effective to delay tumor progression and improve PFS. What we did in CLARINET FORTE is to take a group of patients who had progressed with lanreotide 120 every 28 days and shift them to the double dose 120 milligrams every 14 days. So we included patients both from pancreatic and midgut origin. Those with pancreatic origin had grade 2 tumors in majority, while those with the midgut primary had in majority grade 1 tumors. All tumors expressed somatostatin receptors. And so what we are now anxiously waiting for, and will come soon by the way, Q1 2020, are the results of this study, and we expect to prolong PFS by doubling the dose of this somatostatin analog, and this could be interesting because it could prevent the too early use of more aggressive treatment in those patients. The SANET-ep study is a randomized study performed with a tyrosine kinase inhibitor, Sorafenib, which targets VEGF and FGF receptors. It's a new TKI inhibitor. We already have some of them, and this is a randomized study in non-pancreatic neuroendocrine tumors to study the effect of this drug as compared to placebo in a 2-to-1 randomized fashion. The main result of this study is that the progression-free survival was a little bit more than 9 months with Sorafenib, while it was only 3.8 with placebo. Side effects are not rare as with TKI inhibitors, especially hypertension and proteinuria. We do not have many randomized studies in this disease, and this is a well-done phase 3 randomized study. PFS is significantly prolonged by this TKI inhibitor. We already have some TKI inhibitors. The place of this new one will have to be defined more thoroughly by subsequent studies. I think that neuroendocrine tumors are extremely complex. We now have a large choice of treatments, including somatostatin analogs, PRT, chemotherapy, targeted therapy, alone or in combination. And I think that those 3 studies presented here are making some advance in understanding how we can propose those treatments and improve the survival and at least the progression-free survival of our patients.